Did you guys know that periodontal diseases weren't always classified the way we study them today? Before 1999, ang ginagamit na terms were adult periodontitis and juvenile periodontitis. So mostly, nakabase siya sa age ng patient. But periodontologists eventually realized that this system had major limitations. Maraming overlapping categories, unclear criteria, and hindi niya na fully i-explain yung complexity ng periodontal conditions. So, in 1999, the American Academy of Periodontology introduced a new and improved classification system, mas comprehensive, mas systematic, and hindi lang nakafocus sa age, but also in clinical features, severity, and systemic involvement. Okay, share ko lang guys. Someone asked, why do we have so many classifications for periodontal disease? Why can't we just say gingivitis and periodontitis and move on? Okay, let us explain something. Bakit nga ba need natin mag-classify? So, classification helps us diagnose correctly, predict prognosis, plan treatment, understand etiology and pathology, and communicate with other clinicians. So, ang remember lang guys, classification allows logical and systematic organization of periodontal diseases for diagnosis, prognosis, and treatment planning. So, ano-ano nga ba yung mga system before 1999? Ito ay yung World Workshop 1988, World Workshop 1989, GENCO 1990, RANI 1993, and European Workshop 1993. So ang problem talaga nito guys are overlapping categories, too much emphasis on age, no proper gingival disease section, and unclear criteria.
Now that we've talked about why that classification had to change, let's break down the actual structure of the AP 1999 system. The first category and the most important is gingival diseases. This was a major shift because it clearly separated gingivitis from periodontitis. And clinically, that distinction is crucial since gingivitis does not involve clinical attachment loss. Gingival diseases are divided into two main groups, which are the plaque-induced and non-plaque-induced. Let's begin with the plaque-induced gingival diseases. These diseases can occur with no attachment loss or with stable attachment loss. And there are subcategories. First, gingivitis associated with plaque only. Second is modified by systemic factors like puberty, menstrual cycle, pregnancy, diabetes. And the third is modified by medication, like phenytoin, cyclosporine, and calcium channel blockers. And the fourth one is modified by malnutrition, like vitamin C deficiency. And you must not forget that gingivitis does not cause clinical attachment loss. Let's proceed to the second group of gingival diseases, which is the non-plaque-induced gingival lesion. This lesion is caused by specific bacteria, viral infections, fungal infections, genetic conditions, mucocutaneous disorders, allergic reaction, trauma, and foreign body reactions.
Now let's move on to chronic periodontitis. Chronic periodontitis replaced the old term adult periodontitis. It's the most common type and usually progresses slowly over time. We classify chronic periodontitis by extent and severity. By extent, it is localized and generalized. Localized, less than 30% of sites are involved, while generalized is more than 30% of sites are involved. By severity, it is measured by clinical attachment loss. Slight 1 to 2 millimeters of attachment loss, moderate 3 to 4 millimeters of attachment loss, and severe 5 millimeters or more. Next, we have aggressive periodontitis, which replaced what used to be called early onset periodontitis. It shows rapid destruction of periodontal tissues and may have a genetic component. It can appear as localized or generalized depending on how many sites are involved. Periodontitis is manifestation of systemic diseases. Some periodontal problems are linked to systemic conditions. These includes blood disorders such as neutropenia and leukemia, and genetic syndromes like Down syndrome, Papillon-Lefebvre syndrome, leukocyte adhesion deficiency, and Ehlers-Danlos syndrome. In these cases, the systemic disease drives the periodontal destruction. Next, we have necrotizing periodontal diseases. These are acute, painful conditions with necrosis and rapid tissue destruction. They include necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis. They are often seen in immunocompromised patients such as those with HIV. Moving on to periodontal abscess, these are localized collections of pus in the gums or supporting tissues. Types includes gingival abscess, which is limited to gingival tissue, periodontal abscess, which involves the supporting periodontal tissues, and pericoronal abscess, which occurs around a partially erupted tooth. They often require immediate intervention. Combined perioendo lesions involve both the periodontal tissues and the tooth pulp. The treatment depends on which part is primarily affected, either the periodontal or the endodontic component. Now let's look at the developmental or acquired deformities that can predispose the teeth to periodontal disease. These include gingival recession, lack of keratinized gingiva, aberrant frenum or muscle attachment, and occlusal trauma. Correcting these factors helps prevent further periodontal breakdown. So we have here the table, the synopsis of types and characteristics of gingival diseases, its causes, signs and symptoms, and treatment that you can use to understand and manage each type effectively. To summarize, the 1999 AAP classification gave us a clearer system. It separated gingival diseases, replaced adult with chronic periodontitis, replaced early onset with aggressive periodontitis, added categories like systemic disease, associated periodontitis, necrotizing periodontal diseases, abscesses, and developmental or acquired deformities.
And that's it. This is Miss Cynthia.